Yeah, over to you, Dr. Amriti Baveja.
Thank you, Kushiti. A very good evening to all of you. I welcome you for the masterclass in hematology organized under the aegis of ISHPC, the Indian Society of Hematology and Blood Transfusion. Today's topic is management of thalassemia, and it gives me an immense pleasure in introducing the speaker of the day, Dr. Rajiv Dey, Professor, Department of Hematology, NRS Medical College, Kolkata. Since I know him personally, and though he is a renowned person who has done a lot of work in hematology, but he has a personal interest in thalassemia, and he's an excellent teacher and an academician. Now I welcome Dr. Rajiv Dey for his class.
Yeah, thank you, Dr. Abriti. Thank ISHPT organizer for this opportunity to allow me to talk on the topic management of thalassemia. So this is a master class. I think this is a class mainly dedicated for the students. So my presentation is like a class only, not like a typical presentation in conference or CME. And I thank Abriti for her kind introduction. So the duration of my talk is 45 minutes followed by a 15 minutes discussion. So we know the structure of hemoglobin, which consists of mainly 4% of heme molecule and 96% globin. So as we know, the most of the function of hemoglobin, what we know as well, that is the transport of oxygen and carbon dioxide, that is mainly done by the heme. So what is the function of 96% globin? And we know that nature doesn't create anything for no use. So basically globin is there to give hemoglobin molecule the stability. So if there is an abnormality of the globin chain, the hemoglobin becomes fragile. So that when thalassemia is like that only. So thalassemia is the abnormality of the globin chain, which makes hemoglobin molecule fragile, and it causes the destruction of hemoglobin molecules at its formative phase in bone marrow. And so it is essentially a ineffective erythropoiesis rather than a typical hemolysis or hemolytic anemia, which is basically destruction of RBCs. But the global burden of thalassemia is huge because hemoglobinopathy is the commonest monogenic disorder globally, although mostly it is sickle cell, but there is at least 3 lakh to 4 lakh babies with a severe hemoglobin disorder are born each year. And worldwide, around 60,000 conception with major thalassemic disorders in every year. And if we see our Indian statistics, basically this global thalassemia review published in 2021 by TIFF, Thalassemia International Federation, to gives us a glimpse of the nature of thalassemia prevalence and thalassemia burden in different countries. So they have mentioned each and every countries depending on the available literature published from those countries. And as per that literature, that review, we can see that this is the scenario of beta thalassemia, let's say hemoglobinopathy carrier status in the world. And we see that in India and the Southeast Asian countries, the Middle East, they are prevalent for the major hemoglobin disorders. And mainly this is for beta thalassemia carrier. And E trait, if we see that they are mainly prevalent in the Southeast Asian countries, and amongst India, the northeastern states and the eastern states, including West Bengal, they have a very high prevalence of hemoglobin E. And sickle, as far as India is concerned, it is located in few states only, Odisha, Madhya Pradesh. And the global prevalence of thalassemia is very much similar to the world distribution of malaria in last 20 years. It is also mentioned in the TIFF guideline. So they mention these articles to assess the prevalence of Indian scenario. So if you see that it is not a representation of all the states. Basically, there is mostly the states.
So you need to unmute yourself.
Yeah. So if we see that all the states are not represented in this TIF manifesto. So the states which are mainly represented are Gujarat. 4 articles are from there, Maharashtra and West Bengal. So as per these statistics, there are 3 to 4% are carrier rate of beta thalassemia carrier rate in India, and 35 to 45 million carriers are there in our multi-ethnic population, and it is basically a burden to our thalassemic patients, are really a burden to our healthcare, because the prevalence of hemoglobinopathy in India is 1.2 per 1,000 live births, and 10 to 12,000 thalassemic children are born annually, and it is very much underreported. We know if we calculate properly, the total actual number of thalassemic will be much more compared to what is mentioned over here. And we know that there is a alpha and alpha-like chains and beta-like chains in chromosome number 11 and 16 respectively. And there is a switch in the perinatal phase, and so the HbF is converted to adult hemoglobin. So if there is a quantitative abnormality of the norm of the beta globin chain, so there is relative increase of the fetal hemoglobin HbF, and that is characterizes the beta thalassemia. And we can see that from the fetal life to the adulthood, there is sequential changes in the different globin chains, and the adult hemoglobin, that is alpha to beta 2, takes its mature percentage from 6 months postnatal to 1 year postnatal phase. And the chain which is defective and causes the quantitative abnormalities names the type of thalassemia. That is, alpha thalassemia means there is deficiency of alpha thalassemia, beta means there is deficiency of beta thalassemia. But as there are other structural hemoglobinopathies also, like sickle, like E, so there is often compound heterozygous of thalassemia as well as some hemoglobinopathies, so which also extends the complete thalassemic syndrome. That is, it may be a homozygous status for thalassemia, or it may be a compound heterozygous with thalassemia and a hemoglobinopathy like E beta thalassemia, sickle beta thalassemia, etc. Now, as far as phenotype is concerned, we name thalassemia as TDT and NTDT. That is transfusion dependent thalassemia and non-transfusion dependent thalassemia. And thalassemia trait, or so-called thalassemia minor, we don't consider them as a thalassemic patient. As far as the pathophysiology of thalassemia is concerned, this is important. This is important from the management perspective, because in thalassemia, the defective gene is not responsible for the clinical manifestations. It is the unpaired normal globin chain, which actually causes the destruction of the RBCs. So in suppose beta thalassemia, beta chains are less in amount. We know that hemoglobin is water-soluble molecule, but individual globin chains are water-insoluble. So in beta thalassemia, the unpaired alpha chain actually precipitates within the cells while they are in the bone marrow in the formative phase, and they causes this individual alpha globin chain. They causes membrane destruction, and this membrane destruction causes a flip-flop mechanism. Phosphatidylserine, which is there inside the cells, they comes out. And this exposure of the phosphatidylserine, they send apoptotic signals and causes apoptosis. So this is the mechanism of the thalassemia. This is a pathophysiology of thalassemia. Now, so there is actually increased erythropoiesis. There is almost 8 to 10 times more erythropoiesis compared to the normal population. So the thalassemia problem, if we want to counter or manage properly, then we need to suppress that ineffective erythropoiesis. So as per the phenotypic diversity, the the total syndrome of thalassemia is divided into TDT and NTT. Basically, that is a continuum. TDT means transfusion dependent thalassemia, those who needs regular transfusion for survival. The NTDT may sound like a misnomer because non-transfusion dependent thalassemia, it may sound like they don't need transfusion, but actually it is not. Basically, they don't need transfusion for survival, but they need transfusion for other reasons. They need transfusion for some emergencies. They need some transfusion for ineffective erythropoiesis induced manifestations like extramedullary hematopoiesis, facial deformity, growth and development problem. They may need transfusion for these reasons. So they don't need transfusion, regular transfusion for survival, but they need transfusion for other indications. And as I mentioned, so there are a lot of manifestations. They can cause facial deformities because of bone marrow expansion. There is increased iron absorption from the gut. There can be increased iron overload from the blood transfusion. They can cause iron overloading, causing cardiac hemosiderosis, causing endocrinopathies, so on and so forth. For NTDT, the pathophysiology is same. The thing is, as the abnormal cells, abnormal RBCs are not replaced by the fresh RBCs, they develop a lot of hypercoagulopathies and vasculopathies and cellular changes. Basically, so they are mainly characterized by leg ulcers, different thrombotic events, pulmonary hypertensions, as well as iron overload, mainly because of increased iron absorption from the gut, and they causes endocrinopathy and features of iron overload like beta thalassemia major as well. So complications are like this: anemia, iron overload, endocrine complications, osteoporosis, cardiac complications, different infections, mainly in splenectomized patients, other complications of splenectomy, and definitely the psychosocial issues. So it is a multi-system disorders and causing lot of clinical manifestations like this: leg ulcer, stunted growth, psychosocial complications, splenectomy and its complications, delayed puberty, defect in growth and development, thrombotic complications, this thing. So we have guideline by Thalassemia International Federation. Usually, while managing thalassemia, we follow this guideline in our day-to-day practice. If we don't do any specific clinical trial in thalassemia. So this guideline on TDT published in 2021, and the latest guideline on NTDT published in 2017. So my talk on the management of thalassemia will mainly based on this guideline, along with some references from other sources. And we have there is national, that is NHM guideline also published in 2019. So this National Health Mission, under this National Health Mission, we have now HCP, hemoglobinopathy and hemophilia control program, and different states has adapted this program, and my state, West Bengal, also part of it. So we run our thalassemia control program under HCP, hemoglobinopathy hemophilia control program, which is under National Health Mission. So the management of thalassemia is mainly the blood transfusion, then iron overload, splenectomy, management of endocrine complications, osteoporosis management, management of cardiac complications, and then as far as the curative aspects, stem cell transplantation and gene therapy, and definitely the psychosocial support. So the transfusional management, it is the most important component of thalassemia management. Now, the philosophy is of transfusional management thalassemia is the patient is having anemia. So, we need to transfuse them with RBCs as the patient is having anemia. At the same time, the main problem of thalassemia is ineffective erythropoiesis. So we need to transfuse the thalassemic patients so that their ineffective erythropoiesis is suppressed, and by that way, the other complications of ineffective erythropoiesis will be managed. So we need to balance the transfusion, RBC transfusion, so that ineffective erythropoiesis is adequately suppressed. So there are some criteria for starting transfusion. That is, if hemoglobin is less than 7 on 2 occasions at 2 weeks apart, so that is an indication for starting transfusion. But there are other criteria also. If there is significant symptomatic anemia, if there is poor growth development, if there is complications of extramedullary hematopoiesis, or there is significant extramedullary hematopoiesis, these are also indications along with the first indications like the hemoglobin cutoff of 7. Now, which blood product is to be given? So it is said that relatively young, relatively fresh blood needs to be infused, so that the post-transfusion survival is there within the patient's body. So PRBC stored for less than 2 weeks is ideal for transfusion, and better to give a leukodepleted blood product, that is a blood product with less than 1 × 10⁶ leukocytes per unit, because the leukocytes are associated with a lot of complications, especially in thalassemia. So they can causes transfusion-related infections, complications. They can causes febrile non-hemolytic transfusion reaction. They can help to produce alloantibody formation, anti-HLA antibody formations. So that's why leukodepleted blood product is preferred. Now, before starting thalassemia transfusion, because as the patients are chronically transfused, patient will be chronically transfused. So we need to give a phenotype match, at least a limited phenotype match RBC, because otherwise they can produce an alloantibody formation. Because it is a common problem what we see in chronically transfused, mainly in TDT patients, TDT and both in NDT patients also, that after few transfusion, the hemoglobin doesn't have an expected rise following transfusion. So if we check, we can see that there is around 20 to 30% cases that alloantibody are formed. So that's why along with A, B, and D, we need to do the RBC phenotype for capital C, small c, capital E, small e, and KIL. So this 5-panel extended RBC is essential for the thalassemia transfusion, and we need to give this limited phenotype matched RBC transfusion. And in regular transfused patient, we need to do an alloantibody screening also. And what should be the threshold for beta thalassemia or for TDT? The pre-transfusion threshold has kept between 9.5 to 10.5, because it has been seen that it can adequately suppress the ineffective erythropoiesis. If we keep the pre-transfusion hemoglobin between 9.5 to 10.5, the ineffective erythropoiesis will be around 2 to 4 times of the normal. So that is manageable. But if we want to maintain the normal, there are different transfusion strategy, hypertransfusion, supertransfusion. So if we want to maintain the normal hemoglobin, then the amount of blood to be transfused would have been huge, and the amount of iron overload will be so huge that it would be difficult to reduce them by iron chelation. So this is the standard pre-transfusion threshold, which is recommended by TIF for TDT. For E-beta thalassemia or for NTDT, there is no strict cutoff. TIF has mentioned that if the hemoglobin is less than 5, then we should transfuse, or if the patient has other indications for transfusion. And we have seen that if we maintain the hemoglobin of 5, definitely patient develops other complications like facial deformity, extramedullary hematopoiesis, defect in growth and development. So in our institute, we maintain a cutoff of 7 gram per DL. And in different studies also, they have shown that if they maintain 7 gram per DL, the patients usually maintain the normal growth, development, and the level of ineffective erythropoiesis also are significantly suppressed. So the mean target hemoglobin is 12, the post-transfusion hemoglobin is 12 to 14, and pre-transfusion is around 9.5 to 10.5. For E beta, we keep it around 7, but it is not standardized. There is an formula of what should be the volume of blood which needs to be transfused. So it is there. And when the hemoglobin doesn't rise adequately even after transfusion, so these are the possibilities. There can be alloantibody formation. There can be features of hypersplenism. There can be an older blood, poor quality blood. There can be any other sources of bleeding, like bleeding piles or bleeding from gut, anything. So that we need to find out. Leukodepletion, that I already mentioned, and there are 3 types of leukodepletion. Pre-storage, that is when leukodepletion was done before RBC preparation, PRBC preparation. Pre-transfusion, when the leukodepletion done after PRBC formation, PRBC preparation, and bedside filtration. And best is definitely a pre-storage filtration. And it can prevent the non-hemolytic febrile transfusion reaction, HL alloimmunization. It can prevent the trailing or the that is WBC transmitted infections can be prevented, like CMV, Epstein-Barr virus, etc. Worst RBC, sometimes it is used for allergic reactions, because sometimes patient may develop allergic reactions after transfusion, which is mainly plasma proteins. So that can be cleared by washed RBC, but it has some fallacies also. It can, if we wash RBC, then it can reduce the hemoglobin content. It becomes an open system. Chances of infections will be more. So these are there. So it is nowadays not that much practiced. There are other RBCs, I think, which is mainly theoretical, and it doesn't have that much significant value. And in day-to-day practice, we don't use these products, like cryopreserved RBCs, by donor apheresis, by neocyte transfusions. Pros, cons are there, but usually it is not a routine practice to use this. So this is the summary. Basically, there is nothing new. I have already covered all these issues. Basically, before putting a patient on regular transfusion, we need to see whether the indications for transfusion was a transient indication or it is a regular indications. So in thalassemia, in TDT patients, definitely we need to keep the pre-transfusion hemoglobin 9.5 to 10.5 for normal growth and development. But for NTDT, we need to decide. It is individualized. But definitely before starting a regular transfusion, we need to do an extended RBC phenotype and to give leukodepleted phenotype matched blood. And if patient doesn't respond adequately to transfusion, we need to look for the alloantibody formation. So this is there. Complications: acute transfusion, chronic transfusion complications, transfusion infections. This is there. Acute transfusion reactions is mainly the most commonly febrile non-hemolytic transfusion reaction. It can be acute hemolytic transfusion reaction because of ABO mismatch, mainly allergic reactions because of plasma proteins. Then TRALI, TACO, these things can be there, and coagulopathy also can be is a possibility if there is a massive transfusion, and infections. Chronic is alloimmunization. TAG, VHD can be there, so we need to avoid the family donors for that. And definitely the long-term complications of transfusion, like iron overload and transmitted infections. Alloimmunization, I have already mentioned. The most allogenics are usually capital C and KEL, but other are also responsible. There is 20 to 30% chances of alloimmunization. And chances of alloimmunization is much more in NTDT compared to TDT. That is, those who receive infrequent transfusion or intermittent transfusion, the chances of alloantibodies are much more there. TAG, VHD is another complications. Infections, hepatitis C, B, HIV, and CMV, it is there. So there should be a safe transfusion policy involving the blood bank, the physicians, as well as patient and patient's relative for a safe transfusion. Now, then the next complication of thalassemia is iron overload, that we know that normally around 2 grams of erythron are required to produce our normal RBCs per day. And the source are mainly the macrophages, which the source is basically the destroyed RBCs regularly, and gut, where 1 to 2 milligram of RBCs of iron are absorbed, and it is transmitted by transferrin, and the transferrin keeps iron in the safe transferrin bound form. But if there is iron overload, be it because of increased absorption from the gut or because of this increased transfusion, so the reticular endothelial system can be saturated, transferrin may be saturated, and there can be formation of NTBI, non-transferrin bound iron. Basically, this non-transferrin bound iron, that is a labile iron, that is the toxic to cells, and they cause a lot of cellular toxicities and organ toxicities. In NTDT, the main source of iron overload is gut and occasional transfusion. So this labile iron or non-transferrin bound iron, they produce a reactive oxygen species, causes lipid peroxidation, cellular damage, and a lot of other complications like cardiac failure, liver cirrhosis, endocrinopathies, infertility, and cellular damages, as well as vasculopathy. So that they cause. Now, monitoring, the ideal monitoring is liver iron concentration, assessment of liver iron concentration, but the other methods are serum ferritin. Liver iron concentration usually previously we used to do liver biopsy, but it is an invasive. Now we estimate liver iron estimation by MRI of liver or MRI heart. SQUID is not available, so it is not. So important is serum ferritin, which is available in almost all the centers where thalassemia patients are being treated. But there are some fallacies, and nowadays the ideal method of iron estimation is MRI of liver and iron. So cardiac iron estimation and liver iron estimation we can do by T2 star MRI. There are fallacies in ferritin. We know that advantage are a lot because it is available, it is inexpensive, and it can be done. But disadvantage are they are acute phase reactant, and in NTDT they actually don't represent the total iron overload. The ferritin doesn't represent the total iron overload, mainly in NTDT. And LIC is ideal. It is best done by MRI, but again it is expensive and it is not available in all the centers. Although 1.5 Tesla MRI machine is sufficient for that, but we need to have a standardized software, and need to do it regularly. So many of the centers in India performs LIC. We have one center in Kolkata also. So this is the estimate. We can see that serum ferritin, as far as the thalassemia measure is concerned, it maintains a linearity. But for thalassemia intermedia or NTDT, the serum ferritin doesn't represent the total iron concentration. That is LIC. For a particular LIC, the serum ferritin level is low as far as the thalassemia intermedia or NTDT are concerned. And that's why the threshold for starting chelation is low if we assess the iron overload by ferritin only. So, and this is the monitoring of iron overload. This recommendation. And after it needs to be done every 3 monthly by serum ferritin, and every 6 monthly to 1 yearly by liver MRI concentration. Now chelation. So what is the principle of chelation? Chelation is nothing but we bind the labile metal with a chelator and form a metal chelator complex, which is safe complex, which is non-toxic, and it is excreted either by stool or urine or both. So the strategies are preventive therapy, that is before starting chelation, before adequate or significant iron overload is there. Rescue therapy, when there is already iron overload, we are treating to reduce the iron overload. And emergency therapy is when the patient develop complications of iron overload, like cardiac failure. In those cases, often the combination of iron chelators are used. And dose adjustment are necessary. It is not that once we start the chelation and just the patient go on taking it, because there are complications of iron chelator also. We need to adjust our dose as per the iron overload. And we need to ensure that there is adequate adherence to the chelation therapy. So we need to first prevent the accumulation of iron by starting treatment enough before the iron accumulation, then and to minimize the toxicity. So these are the available iron chelator, desferrioxamine, which is hexadentate 1:1. It forms very strong compound with iron. Then deferasirox, the tridentate 2:1 combination, then deferiprone. Because of some side effects, deferiprone usually not commonly used nowadays. So deferasirox, most commonly the molecule used for chelation is now deferasirox, and in some cases we use desferrioxamine, especially before transplant, when we need to rapidly reduce, when if the patient develops complications like cardiac failure. So we use desferrioxamine or double chelator. Yeah. So delivery for desferrioxamine is mainly subcutaneous or continuous IV. Half-life is 20 to 30, and it needs to be given at least 5 days a week, because as labile iron are there in the plasma, so we need to ensure that the chelators are present continuously in the plasma for effective chelation. So according to the half-life, we ensure that the patient we adjust the doses, so that we ensure that there is 24 hours presence of chelation in the plasma. As far as deferasirox is concerned, it is orally available. It is 12 to 16 hours is half-life, and that's why we give once daily dose. And deferiprone, the half-life is 3 to 4 hours, so we give TDS 3 times a day. The recommended dose of desferrioxamine is 30 to 60 milligram per kg, 5 to 7 days per week. For deferasirox, depending on the TDT and NTDT, the doses varies. For TDT, the dose ranges from 10 to 20, maximum 30. For TDT, the ranges is 20 to 40 milligram per kg once daily dispersible tablet, or we can use now a film coated tablet. The dose is 70% of the dispersible tablet. And for deferiprone, 75 to 100 milligram 3 times a day. So when to plan? If the patient is more than 2 years of age, there is 10 to 20 transfusions, or as far as TDT is concerned, if the ferritin level is more than 1000, then we should start. And we need to stop when there is ferritin is less than equal to 300, or LIC, liver iron concentration is 3 milligram per gram per day. And intensive or combined chelation to be given when the ferritin level is more than 2500 or LIC is more than 15 milligram per gram, or sometimes before planning bone marrow transplant. For NTDT, the cutoff is 800. The cutoff, the threshold is usually less compared to the TDT. So if it is less than equal to 800, then we start chelation at a dose usually at 10 milligram per kg, and we adjust accordingly. And if it is less than 300, we stop, but we monitor. There are some different guideline how to escalate, how to de-escalate. So and we need to monitor that, because to reduce the chelation related complications, chelation related side effects. We need to regularly do the ANC if we give deferiprone, but for other chelators it is not necessary. But creatine assessment needs to be done for deferasirox twice before starting, and then weekly for first month, and then monthly. Usually we do 3 monthly in our center. For ALT-AST assessment, that is also we need to regularly follow for deferasirox as well as for desferrioxamine. Puriton audiometry and ophthalmology annually needs to be done for deferasirox. So this is sum up of the deferasirox therapy because we give it regularly. That's why. So TDT more than equal to 2 years. For NTDT, usually it is more than equal to 10 years, but we can start early and we need to titrate as per the guideline. We need to monitor the patients for the chelation-related toxicities, as I already mentioned. Splenectomy is also an important component, but the thing is, when a patient needs splenectomy, if a patient needs splenectomy, that means the patient was not properly managed. Usually, practical recommendations are aged more than 5 years, worsening of anemia leading to poor growth and development, hypersplenism, massive splenomegaly, the splenic infarction. So these are the indications for splenectomy. But it is associated with a lot of complications also, and we need to be very cautious about that. Especially, we need to give a immunoprophylaxis, and post splenectomy, we need to give chemoprophylaxis with penicillin at least for 5 years. So these capsulated organisms are very common post splenectomy, so we need to give essential vaccination like H. influenzae, pneumococcal, meningococcal, and influenza. And but you know, and all this is supportive care. So to cure thalassemia, the transplant is the only option at present. And another strategy is there, that is the hemoglobin F induces. Because I have already mentioned at the beginning that it is not the defective globin which is responsible for the pathophysiology. It is the normal unpaired alpha chain which is responsible for all these complications. So if we can balance somehow, and the easiest way to balance is by inducing gamma chain, so that the alpha chain gets its companion in gamma chain and it forms the HbF. We know that there is a switching in the perinatal phase, and the main component of this fetal to adult switching is BCL11A. They help in switching. So, in BCL11 polymorphism, often we see that there is an increased HbF because the switching is halted. And by stimulating this BCL11A, we have different strategies, including this is gene therapy, which can help to prevent the imbalance of alpha and non-alpha. So genetic modifiers for beta thalassemia is co-inheritance of alpha thalassemia. The symptoms will be less. If there is triplication or quadruplication of alpha thalassemia, then beta thalassemia carrier state also can behave like a thalassemia intermedia, and the percentage of hemoglobin S. So different genetic modifiers are there for HbF induction, like XMN polymorphism, BCL11A polymorphism, KLF1 mutation, which actually controls the BCL11A expression. So MYB, intergenic region. So polymorphism in these genes are responsible for variation in HbF amount and variation in the clinical manifestations also. And this BCL11A plays a very important role, and by inducing the there is a suppressor of BCL11A. So if we suppress that suppressor, then they can act like an inducer for HbF. So in that way also we can increase HbF. So this is a therapeutic target to correct the impairment of alpha beta hemoglobin ratio, that is HbF induction. And hydroxyurea is a known agent for this HbF induction. It prevents the ribonucleotide reductase, and it causes stress erythropoiesis, and this stress erythropoiesis can induce the HbF production. And a lot of studies are there which had showed the benefit of hydroxyurea, and in thalassemia patients also. We have done few studies in our center in Kolkata, which showed that hydroxyurea induces HbF as well as hemoglobin concentration, but there is no linearity between the HbF induction and HbF increase. There is statistically significant, and this optimal study is a very landmark study, and this landmark study also showed the benefit of hydroxyurea in thalassemia patients. Usually the dose is 10 milligram per kg per day, but they can be increased up to 30 milligram per kg per day. These are different studies on hydroxyurea in thalassemia, which showed significant improvement. And for NTDT patients, this optimal care study, they also showed the importance of hydroxyurea in reducing the transfusion burden for thalassemia patient. There can be epigenetic modifiers also which can induce the HbF, and which includes these HDAC inhibitors or DNA methyltransferase 1 inhibitors. So they are also there, like decitabine, azacitidine, short chain butyric acids. These agents can induce HbF, and we have few studies in different centers of India as well as in Calcutta Medical College. There is studies with decitabine. There was which showed an increase HbA production and increase hemoglobin production following decitabine injection compared to the normal population. There is showing HbF at successive follow-up visits compared to hydroxyurea. It showed increase in the HbF level. And there are some thalidomide studies also, and in different parts of internationally as well as in different parts of India, which showed that thalidomide also important in inducing HbF as well as in increasing the HB hemoglobin values. So these are studied by the Vijay Ramanan, who showed the improvement of HbF level and hemoglobin level after giving thalidomide in beta thalassemia major patients. And this multi-center study using thalidomide in NTDT patients, it was shown that thalidomide actually can cause HB increase as well as HbF increase. So a lot of studies are there, so I'm not going into detail. So both TDT and NTDT patients were included in this study, and overall response rate was 93.5%, and major and minimal response was 62%, 0.9%, and 30.6%. And this study was done in Tata Medical Center, Kolkata, to see it is a retrospective study in E beta thalassemia giving thalidomide. And here also they showed that there is increase in the hemoglobin those who received thalidomide. There is 76.1% overall response as far as the hemoglobin amount is concerned. And this study was done in our center, University Medical College. That it is a 3-arm comparative study, placebo versus hydroxyurea versus thalidomide in E beta thalassemia. It is the first international study, randomized study, where in E beta thalassemia, the thalidomide compared to hydroxyurea and placebo were assessed. And it showed that there is significant increase in hemoglobin level, and it was raised as high as 2.13 gram per dl, and there was significant reduction in the blood transfusion those who were on thalidomide. So the first documented study on E beta thalassemia patients, and so there are a list of HbF inducers like decitabine, azacitidine, hydroxyurea, short chain fatty acid, and thalidomide. So they have shown some improvement in HbF level. And then the curative aspect, the curative treatment is, the practical curative treatment is definitely transplant. And is long-term transfusion and chelation-free life can be achieved. And we know that after starting transplant, there is significant improvement in the overall survival over years. So if you compare the thalassemia survival in 1960s to 90s, so there is significant survival advantage, mainly because of this bone marrow transplant. And there is 80 to 88% improvement in the overall survival following matched sibling donor transplant. And this study in HLA matched sibling bone marrow transplant for beta thalassemia, there was 19 centers, and 50% were from India. Myeloablative conditioning were Bucite ATG in most of the cases, and it showed a significantly improved outcome. Mainly in PESARO-1, the outcome was very good. The class 1 usually have overall survival of 94%. Class 2 is 77%, but class 3 has got an overall survival of 53%. So, the transplant cannot be the like magical process if we don't manage thalassemia properly. If we don't do a proper transfusion, if we don't chelate properly, then the outcome of transfusion is not good. So basically, we need to treat the thalassemia from beginning so that the patient remains in class 1 or class 2, and then the full advantage of transplant will be achieved. And now, altering that conditioning regimen, we can have a good outcome even in class 3, but we should try to keep the patient in class 1 or 2 by proper non-transfusion management, and then we can get the actual advantage of transplant. There are some novel therapies also in thalassemia now. So novel therapy in different aspects as far as iron overload is concerned, iron chelation is concerned. So there is different novel therapies. The one is luspatercept. It is now coming to India. So it is an erythroid maturation agent acting on the late stage erythropoiesis. It is the first in class erythroid maturation agent that neutralizes TGF beta superfamily ligand, and they actually enhance the late stage erythropoiesis. And if we give luspatercept, there is around 22 to 25% improvement. How much improvement? Around 33% improvement in the transfusion requirement in TDT patients. But it needs to be given subcutaneously, and patient may need to come every 3 weekly to the centers where it is available. Gene therapy is another therapy. So gene therapy has two strategies. One is gene addition or replacement by correcting the abnormal gene by lentivirus method. But there can be a gene editing also. This gene editing basically manipulate BCL11A or KLF1, and they increase the HbF level and decreases the alpha non-alpha imbalance. So by gene editing method, thalassemia can be controlled, can be managed. And these are the different gene therapies. That is the Betisel method, which causes insertion of modified beta globin. That is GLOBE method, or there can be CRISPR-Cas9 or zinc finger directed method. So there are different novel medications for beta thalassemia: luspatercept, sotatercept, sirolimus, to prevent the iron absorption, apotransferrin, and ruxolitinib also can be used as a JAK1/2 inhibitor to reduce the ineffective erythropoiesis and reduce the splenomegaly. Hepcidin mimetics can be used for decreasing iron absorption. These things are there on different phases of trial. So in future we can see the novel agents outside this transfusion chelation, and transplant. There are few, after this overview of discussion, there are few case discussions. I will rapidly go through it. So a 27-year-old female presented with sudden onset paraparesis, MRI finding showed a paraspinal mass. So if a thalassemia patients develop a sudden onset paraparesis, we need to see the paraspinal areas by MRI, and the biopsy from the mass showed that there is features of extramedullary hematopoiesis. And the CBC showing that there is hemoglobin is 7.7, there is microcytic hypochromic anemia. But while doing this thing, HPLC, it's showing a beta trait status. When we did the ARMS PCR for beta mutations, we found IVS15 heterozygous. But when we did the alpha mutations, there was triplications of alpha thalassemia. So if a beta trait is behaving like a thalassemia intermedia, having extramedullary hematopoiesis, so we need to look for alpha triplication or alpha quadruplication. And in case of extramedullary hematopoiesis, we need to manage it properly. We need to keep the hemoglobin, pre-transfusion hemoglobin, a little higher threshold to suppress the ineffective erythropoiesis. It is better to keep more than 10. In emergency condition, we can give the local radiation therapy, and definitely hydroxyurea needs to be given for HbF induction. So these are the management of extramedullary hematopoiesis. This is the algorithm given in the TIF guideline: low dose radiotherapy, short course transfusion, as well as hydroxyurea. So it is the treatment modalities. Often thalassemia patients present with hypercoagulability, and there can be infarction, cerebral infarction also. So venous thromboembolism is not rare, specifically in NTDT patients. And if we because the main mechanism of thromboembolism or thrombotic manifestations of in thalassemia is, here the RBCs are defective. So following the membrane injury, either by reactive oxygen species, by labile iron, or by this unpaired alpha chain, there is flip-flop. And this flip-flop means the phosphatidylserine serine is come out in the outside. And this phosphatidylserine serine provides a phospholipid surface. So actually, in thalassemia patients, mainly in NTDT patients or inadequately treated TDT patients, the RBC behaves like an activated platelet. So in that way, they causes vasculopathy and promote the hypercoagulability. So we need to have we need to keep this thing in mind, the hypercoagulable manifestations. This patient of thalassemia intermedia, 47-year-old, may develop a sudden onset chest pain, dyspnea, and echo finding may show the features of pulmonary hypertension. There can be a pulmonary embolism also. So, average 30% of patients of NTDT may develop pulmonary hypertension. The range varies from 10 to 78.8%. And it should be confirmed by right heart catheterization, but echocardiography also, by assessing the tricuspid valve regurgitation, can give an idea of pulmonary hypertension. Advancing age, splenectomy, history of thrombosis, these are contributing factors in pulmonary hypertension. If TRV is more than 2.5 ml per second, then patient may be asymptomatic. But if the tricuspid velocity is more than 3.2, the patient is likely to develop pulmonary hypertension, and patient may need more frequent transfusion and adequate treatment for pulmonary hypertension. Hydroxyurea is an important component for that. Often sildenafil can be used. There is risk scoring for pulmonary hypertension depending on age more than 35 years, that is beta thalassemia or hemoglobin E, time after splenectomy, Okay, so and this score may help in assessing or in predicting pulmonary hypertension. The patient may develop a chronic back pain. Often the patient of thalassemia develops a bony pain, and DEXA scan may help us to find out whether the patient develop osteopenia or osteoporosis or not. And in cases of if the T score is more than 1.5 standard deviation, then it is osteopenia, and if it is more than 2.5, it is an osteoporosis. And these patients may be, we need to rule out the presence of vitamin D deficiency. The parathyroid hormone needs to be assessed, and they may benefit with bisphosphonates. Bisphosphonates, 1 or 2 doses of bisphosphonate every 3 months. This is also sufficient for osteoporosis, managing osteoporosis in thalassemia patients. Endocrine complications are not very rare. The patient may develop amenorrhea. We need to do, patient may develop hypogonadism, hypogonadotropic hypogonadism, that is the main cause of growth impairment in thalassemia patients. And Tanner staging is very important component of thalassemia management. We need to do regular Tanner staging, especially in the adolescent child. And adequate replacement therapy needs to be given for the growth impaired patients. So we need the help of endocrine department. So thalassemia is basically a multi-system disorders, and we need support from orthopedics, from endocrinologists, from pediatricians, from transfusion medicines. So all these supports is needed for an ideal management of thalassemia. Hypothyroidism, hyperparathyroidism, these things are there. So, considering the current scenario, now we are going beyond the usual management of thalassemia like transfusion, chelation, and as a curative method, transplant. So there are a lot of novel agents, a lot of different strategies. Gene therapies are there. So hope for thalassemia treatment worldwide is there. And there's immense effect in community management of thalassemia, because government is taking up thalassemia control program as a national program. And as a part of that, I think in future, it can be significantly, the burden of thalassemia will be significantly reduced. And we shouldn't forget the preventive aspect. The preventive aspect doesn't mean the only counseling, because it has been seen that preventing marriage from one career with another career is not effective in any country. So to actually, if we want to reduce the thalassemic birth, we need to stringently make the availability of prenatal diagnosis in all the states, all the centers. So by applying prenatal diagnosis, we can actually reduce the thalassemia burden. Thank you. This is the last thalassemia patients which I have transplanted few months back. The patient is doing well. So I'll be happy. So if there is any questions, I'll be happy to take any questions. Thank you.
Summarizing intricacies in the management of thalassemia in such a small time is a tough task. And thank you so much, sir, for such a wonderful class. It indeed was a master class, and I'm sure that all the participants must have benefited and learned a lot from your clinical experience. In the chat box, I can't see any questions, but there are 3 hands raised. So I would request the Riverroot to unmute those attendees so they can ask their questions.
If you have any questions, then you can, not in questions, you can discuss if you think some issues to discuss.
So it was a wonderful class, and it was just a revision, complete revision of all thalassemia, covering like
I
all
was
the aspects of thalassemia.
wondering how to cover thalassemia management in 45 minutes. So I don't know whether I could cover it or not.
No, sir, you have covered almost every aspect, and sharing those clinical cases and giving the bits of all the complications which can be seen in thalassemia. It was a very wonderful session, sir. Thank you very much.
So whether we can conclude the session if there is no question.
Yes, sir.
Thank you very much, sir. And I asked permission from ISHBT's Secretariat to conclude the session.
Okay, so if we do not have any questions in the chat box, or nobody nobody's asking any question, then we can definitely conclude. Proceed.
Thank you. Thank you very much, sir. Thank you very much, sir, for
Yeah. Thank you. Thank you, Avriti, and thank you, ISHBT, for
Thank you, Rajiv sir. Thank you, Avriti ma'am, for coordinating the class.